welcome to our Facebook Live. Today we're going to be talking about hospice care and when it's time for hospice care. So I'm joined again today by Dr. Eric Bush. He's our Chief Medical Officer here at Hospice of the Chesapeake. Thanks for being here again.
Thanks for having me.
So, we're about to approach the holiday season with a lot of family time and a lot of extended time with friends and family that we might not have seen for a while.
Sure.
So there could be some concern about somebody's health and sort of the indicators that it might be time for hospice care or some other level, additional care.
Right.
What are some signs or some things that somebody might be able to look out for?
Sure. So first is the disease process itself. So again, as we had discussed previously regarding advanced or end stage, whether it's cancer, so late stage 3, stage 4, but also for heart failure, so stage D, ACC, AHA, or New York Heart Association class 4, because there are some different classification systems. Also Alzheimer's disease or Alzheimer's dementia, anybody that's in a severe category.
Okay.
And so severe category is somebody that has what we call a FAST score of 7A or worse. But what that is really in layman's terms is somebody that has both bowel and bladder incontinence and a vocabulary of 6 words or less. In general, that's somebody that would qualify for hospice care with dementia. And then there's lots of other disease processes out there. So pulmonary diseases such as end-stage COPD, pulmonary fibrosis, so COPD, someone that's oxygen dependent and generally has had multiple hospitalizations.
Okay.
End-stage renal disease, patients that are dialysis dependent, also again one of the indicators where they've had multiple hospitalizations. And then more globally, changes in functionality. So as somebody's functionality changes, you see grandma, grandpa, they used to get around independently, then they started using a cane, then a rollator, a rolling walker, and now they're really not able to get up and about anymore, either without assistance from somebody, or they're just not able to get up. They're either wheelchair or, unfortunately bedbound at some point.
Okay.
And then one of the bigger indicators, especially that we notice over the holidays, is abnormal weight loss.
Okay.
So people that are unintentionally losing weight. So they say their appetite's good, but you'll notice they're really eating smaller and smaller size portions, kids' meals type portions, fill them up. And so loss of greater than 10% of body mass within the last 6 months unintentionally.
That's a big...
It is a big indicator that somebody that things are just, kind of shutting down, for lack of a better term, and people don't need as much caloric intake as they previously had needed. And then the other indicator is multiple hospitalizations, or, despite aggressive treatment, somebody just isn't getting better. Because again, there is a right time and place for the hospital, obviously, and seeing your physician, frequently.
Right.
But if you're at a point where that return on investment, so to speak, you're getting increasingly aggressive treatments, and your loved one is not getting better.
Right.
That's when it's time for hospice care.
And it's more the revolving door.
Correct.
And then bouncing in from the hospital to potentially rehab, back to the hospital.
Good.
So that sort of...
Correct. And, people have all different trajectories of decline. So some people have abrupt decline. Other people have more of the stepwise decline, especially with non-cancer type disease processes. And what you'll see is they always take a step down functionally, and unfortunately they never get back to their prior degree of functionality, prior degree of nutrition, and those are all indicators that it's a good time to ask at least about hospice care.
Okay, all right. If you're just joining us, I'm joined today by Dr. Eric Bush. He's the Chief Medical Officer here at Hospice of the Chesapeake. And we're talking about health indicators and when it might be time for hospice, because sometimes I feel like people aren't really sure, is it too soon? You don't want to jump the gun. not just, we're discussing some of the health indicators, and it sounds like repeated hospitalizations with not making much health progress,
Correct.
in between, weight loss that's not intentional, and then just some decline in function if you're seeing some changes in the way somebody's mobility or moving around.
Correct. And so also by definition, hospice is for patients that have a prognosis of 6 months or less if the disease were to follow its usual course. Along the lines of what you're asking, is it too early? Unfortunately in our country, the average length of stay on hospice care is 89 days. So it's about half of what it theoretically could be for those with certain ailments. So for example, cancer tends to be actually less, about 52 days on average. Here in Maryland, we are 34th in hospice utilization. So really, there's a lot of patients and families out there that could benefit from this type of multidisciplinary care, support for the patients. It's focused on symptom management and quality as well as quantity of life, because there's multiple studies that show that patients actually that go to hospice, even with advanced cancers, live longer, not only better.
So do you think part of the issue is that people just have it in their mindset from, I don't even know, pop culture, or
Correct.
just, the way the world is sort of works, that it's hospice should only be for the last couple of days, or that's
Correct.
Okay.
Yeah, there's a lot of myths out there. One of them is that hospice is a place. So, and the most common place where patients receive hospice is actually at home.
In their own home.
In their own home. And so about 95% of the patients that we serve as an organization at Hospice of the Chesapeake actually receive at home or where they call home. So whether that's a skilled nursing facility, independent living, assisted living, or home, that's where the majority of our patients receive care. We do have inpatient care centers, which is really the hospital of hospice.
Right.
So patients that do not want to return to the hospital, they can come to our inpatient care centers, which are really home-like settings that provide hospital-level type care to try to get the best of both worlds, because we realize where patients and families are at that point in time.
I believe there's been research too that most people do want to be at home.
Correct.
At those end stages.
Correct. So poll after poll, survey after survey shows about 70% of Americans want to die at home. Unfortunately, it's the flip, it's the opposite. Only about 30% actually do.
That's just so unfortunate.
Right,
and
right.
hoping to sort of change that
Change the culture.
Yeah,
Correct.
change the culture and
Correct.
understanding. So let's talk about that a little bit. What does hospice, let's talk about what hospice care does for the individual who's
Sure.
receiving it, and then we'll talk a little bit about what it does for the other family members, because I think there's benefits
Sure,
for both.
sure. So care for the individual, expert level symptom management, whether it's pain, shortness of breath, nausea, what have you, whatever symptom. There are physicians and nurse practitioners as well as nurses that are involved in the care that can come see you at home. There is also excellent support for day-to-day activities of daily living. So our certified nursing assistants that come and provide care for patients at home, bathing, grooming, things of that nature. So really the family can be the family and the patient can get the care. There are also social workers available for the patient as well as family to support them to identify any resources that may be available, whether it's Meals on Wheels or identifying early bereavement needs that may be there, or complicated family dynamics, or patients that may have young children at home and need that special touch, as well as our chaplains that are there for, and so a lot of people think, well, chaplains, I'm not really religious. That's okay. They're there to support your spirituality, or just to help, again, guide you and be an additional support to help you get through that challenging time.
That sort of makes up the team that you're
Right,
talking
right,
about.
that's the
that
team.
Interdisciplinary team
Exactly.
that kind of deals with a person in the whole instead of just addressing one piece of a person. issue.
Correct.
Just the
And then one of the other questions we get is, well, I don't really have a lot of resources. How does this get paid for? And so hospice at home is 100% covered by Medicare. And again, what we receive as a hospice organization is a per diem, and that's adjusted geographically, but for $160 per day, I can't think of a better bargain in healthcare today. You get care at home by an interdisciplinary team that also covers any medications related to symptom management or your primary hospice diagnosis, any durable medical equipment you need, 3-in-1 shower chair, over-the-bed table, hospital bed at home, as well as any other equipment, things such as oxygen, things of that nature. So whether it's good old nasal cannula oxygen or whether it's CPAP or BiPAP, those are all things that hospice covers.
So it's all incorporated and able for the person
Correct.
to be able to be comfortable and
Correct.
as
Yeah.
okay.
And it's also malleable. So some people say, well, I really don't want somebody coming to my home or all these people coming to my home. Really to maintain appropriateness for hospice care, all you would need to do is see a nurse once every 14 days
Okay.
to maintain compliance with
So
the
it's
Medicare guidelines.
very individualized.
Absolutely.
Based on where the person
Correct.
is in their
Right.
trajectory with
Right.
their
It's meant to meet
disease
patients and families where they are at that point in time.
All right. What about some of the benefits for the family? So,
Sure.
you mentioned one,
Right.
like you're taking the burden off of them for caring
Exactly.
for their loved one.
Exactly. That's really the primary one, is really taking over that caregiver burden and providing that infrastructure and support at home. Someone that can be called 24/7. We have 24/7, 365 support. So if an emergency comes up or if there's a challenge there, typically Friday morning at 3 a.m. As
Yeah.
you know, it's usually
It's the
not.
time.
It's usually not Wednesday at 10 a.m.
Right.
It's Friday
Right.
morning at 3 a.m.
It's a crisis. Well, anytime.
Exactly. You
Anytime.
can call, a nurse can come out if needed, triage, they can get a hold of a physician for oversight and guidance. And then also the social work services, chaplain support services for the family, again, to help identify resources, as well as the bereavement and counseling resources available afterwards for families.
Oh, right. That's a
Yeah.
13-month
Correct.
benefit that
Correct.
families receive after their loved one passes. That
Exactly.
they're able to
Exactly.
really take it.
Just kind of work through things, and everybody grieves just like every patient goes through their disease process individually. The loved one that remains, the bereft, they really go through that process differently
Right.
too as well.
So you mentioned a little bit the myth about hospice being a place. I think I've heard another misunderstanding or myth is that hospice can sometimes make someone die faster, or like that's sort of the concern. But what I'm hearing from you is
Yeah.
that's completely the opposite.
It's actually the opposite. Unfortunately, what happens, it tends to become a self-fulfilling prophecy because people fear hospice and giving up, and it's actually not giving up, it's refocusing the care. And if you think about the risk versus benefit, medicine is like life. There's pros and cons with everything that we do,
Yeah.
including in medicine, and that risk versus benefit changes for each individual over time. The toxicities of the therapies available, and if you think about just logically, as somebody is declining and they have a poor nutritional status and poor functional status, how could giving them something that's toxic help them? So
Right.
actually choosing the wiser course of being more prudent about what you do and don't do, people do live longer and better. And that makes sense if you think about it logically.
Yeah, absolutely. Yeah. So the quality of life, and I'm guessing because you're now supporting the entire family, that plays a role in it as well.
Correct.
Like you've now not only helped the patient
Right.
with symptom management and just been more, but the burden lifted from the family dynamic or the loved one dynamic.
Exactly, lifting that physical and emotional burden from the family allows them to provide the patient with additional support.
Okay. I'm sure, how many years have you been doing this?
15.
Okay. I'm sure in that time period you have had some pretty amazing experiences.
Yeah.
Is there one that you would like to share specifically that sort of you think hits home for what hospice is really meant to do for people?
Sure. And so I had a patient a few years ago who was very sick. She had both end-stage heart failure and end-stage colon cancer. She initially started out on the inpatient level of hospice care.
Okay.
So basically thinking days to weeks type prognosis, a lot of symptom management. She got better and then went to a nursing home while her son prepared to get her home better. And she then went home at about the 3-month mark.
Wow.
And
still receiving hospice
okay. care because she had stage 4 colon cancer and New York Heart Association class 4 heart failure.
Wow.
She had both, and she actually was on hospice for almost a year.
Oh my gosh.
She got to go home. She got to die at home, which were her wishes.
Yeah.
And again, so you don't know. What you can do though is if you support people appropriately for what they need at that point in time, and in this case her son, support her son and make sure he had the infrastructure to care for her at home and have ongoing hospice services. You never know what you're going to get. But this lady clearly had, not only quality of life,
right,
but quantity of life. And while that may not be, the typical, those are the ones that always stand out in your mind. It makes you feel good to be part of that and be able to provide that to people.
That's a huge impact.
Exactly.
That's a huge impact.
Yeah.
So let's say someone is now seeing their family and they're kind of concerned. They've listened to you. They've noticed these indicators. What would be the next step? Like what happens? What should they do?
Sure. Ask their physician about a referral to hospice.
Okay.
Patients and families can self-refer, but we always prefer that there's a referral either from their primary care physician or one of their pertinent specialists, again, whether it's an oncologist, cardiologist, nephrologist, what have you, and ask for a service with Hospice of the Chesapeake. If you're outside of our viewing area, actually there is a great tool called Hospice Compare that Medicare puts out, CMS puts out. If you put in your zip code, you can actually compare hospice organizations within your area that serve your area and find a good quality hospice that would serve you and your loved one.
Awesome.
Yeah.
Awesome. That's super helpful. All right. Before we sign off, I just want to thank the John and Kathy Belcher Institute for their generous support of the community education program here at Hospice of the Chesapeake. I'd like to thank Dr. Bush again for being here.
Thanks, Dan.
And thank you guys for watching.
Great. Thank you.